Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and the Gynecology Faculty of Medicine, Mansoura University. The topic of my lecture today about endometriosis imaging modalities. So what we want to discuss today, the definition, the epidemiology of endometriosis, why diagnosis is delayed, and imaging modalities like transvaginal ultrasonography, MRI, and CT scan. And lastly, we will reach the conclusions. Okay, let us start our journey with the definition. Endometriosis is a disease characterized by the presence of endometrium-like epithelium or stroma outside the endometrium and the myometrium, and this disease is usually associated with inflammatory process. And as you see in this picture, this is different varieties of endometrial lesion. Here endometrioma, here peritoneal lesion in the form of vesicles, also here vesicles, here reddish implants in the peritoneum, and this black implants in the peritoneum also. Okay, so what about the epidemiology of endometriosis? The prevalence of endometriosis from 10 to 15% of reproductive age women, okay? But this prevalence increased and reaching up to 50% in infertility women and 70% in women with chronic pelvic pain. There is possible association between dioxin or other environmental factors and endometriosis. We know that dioxin is present in pesticides and insecticides. So women exposed to this insecticide and pesticide within time may develop endometriosis. Okay, what is the relation between body mass index and endometriosis? Endometriosis occurs more in a slim woman, okay? So why diagnosis is delayed? Diagnosis may be delayed from 4 to 11 years. Imagine how big is the problem. Why diagnosis is delayed? Maybe there is no pathognomonic test up till now or biomarkers that can detect the disease easily. Also, some symptoms like pain or discomfort may be considered as a physiologic response during menstruation. So some women believe that this is maybe normal, this pain or discomfort during menstruation, and all women has something like that. So they didn't ask for the medical advice. Okay. Also, the wide range of reported symptoms overlap with other gastrointestinal or gynecologic causes, may be another etiology for this delay of diagnosis. Okay, so if we have a new diagnostic test, it may be a replacement test or triage test or add-on. Replacement used to replace an existing test by providing greater or similar accuracy along with other advantages. But what about triage test? Triage test is used as initial step in a diagnostic pathway to identify women who need undergo further testing. Okay? Although ideally triage test has a high sensitivity and specificity, it may have a lower sensitivity but higher specificity than the current test or vice versa. Okay? So, triage test, you can consider it as filtration test or test modality used, okay, to know if this woman has a disease or no. So we can exclude some women and go with the suspected woman to another test to reach the diagnosis. This is what is meant from triage test. Okay, what about add-on test? Add-on test used in addition to an existing test to improve diagnostic performance. I mean, we have two imaging modalities or imaging modality and biomarker, for example. With using both, I can reach the diagnosis. So one test improve the diagnostic performance with another test. Okay, so what is the predetermined criteria for replacement test, okay? That which has a sensitivity more than 94% and specificity more than 79%. What about criteria for triage test? Okay, it depends. Is it send-out test or SPEPAN test? In send-out test, sensitivity equal to or more than 95% and specificity equal to or more than 50%. As regards SPEPAN test, the sensitivity equal to or more than 50% while the specificity equal to or more than 95%. So we wanna know this lecture is transvaginal ultrasonography is considered send-out test or SPEPAN test, and the same for MRI, and we will answer this question at the end of this lecture. Okay, let us go to the imaging modality, and this is the core of our lecture today. We have transvaginal ultrasound, magnetic resonance imaging, and computerized tomography or CT scan. Okay? Let us start with the ultrasound. All guidelines recommend the transvaginal ultrasound to be the first line investigation following the history and the pelvic examination in reaching diagnosis of endometriosis. Okay? Okay, as you see in this picture, this is endometrioma, bilateral endometrioma, adherent to each other, both ovaries at the back of the uterus. This is a sign of severe endometriosis. Okay, so let us go to the ultrasound and go systematic when doing transvaginal ultrasonography for women suspected to have endometriosis. Okay, first search for what? First step, routine evaluation of uterus and the adnexia. Okay, then second step, evaluation of sonographic soft markers. What is that? The sonographic soft marker include ovarian mobility, tenderness, and so on. Okay. Then the third step is the assessment of pouch of Douglas and the degree of obliteration. Is it partial or complete obliterated? And using sliding sign with the help of transvaginal ultrasonography. The fourth step will be the assessment of deeply infiltrating endometriosis, and the diagnosis of deep infiltrating nodules in anterior and posterior compartments can be done with ultrasound, as we will see. Okay, so we are going to discuss these four basic ultrasonographic steps. Start first with the uterine position. As you see in this picture, this is AVF uterus, and the other picture, this is RVF uterus, which may be due to adhesions or congenital. Acquired due to adhesion may occur with endometriosis. Also, sometimes there is little retraction of the fundus due to adhesions. You will find retracted upper part of the uterus posteriorly due to adhesion. Okay, to the colon and so on. So this is one of the signs by ultrasound. If you found also any signs of adenomyosis like asymmetric thickness of the anterior and the posterior wall, as you see here, the posterior wall is more thick than the anterior wall in this picture. Okay, and the other signs like diffusely symmetrically enlarged uterus or heterogeneous enlargement of one of the wall, anterior or posterior wall, or endometrial striations directing from the endometrium toward the myometrium striations, or lacunae or anechoic cyst inside the muscle wall of the uterus. All these are signs of adenomyosis. And why we search for adenomyosis while we are searching for endometriosis? Because commonly you may see two pathologies in the same patients, adenomyosis and endometriosis. Okay, and we consider adenomyosis as a separate disease and not a part of endometriosis, as all of us know. Okay, what else? As regard the ovaries, Look for the ovary for endometrioma, which appear cystic structure or mass with low-level homogeneous echogenicity, as you see in this picture, or ground glass appearance, hyperechogenic wall foci. You can see hyperechogenic wall foci in the wall. The wall is thick also in ovarian endometrioma. Okay, and the transvaginal ultrasonography has a high specificity and sensitivity for diagnosing ovarian endometrioma. Okay, but you should know the differential diagnosis of ovarian cyst, whatever benign or malignant. Benign cyst may be simple cyst, as in this picture, you can see it, with thin wall, smaller size, sonolescent, okay? Or hemorrhagic cyst, as in this picture, with reticular pattern, smaller in size. And if you see this patient after 6 weeks, the simple cyst or hemorrhagic cyst may be resolved spontaneously, okay? And it can be diagnosed easily. As I said before, dermoid cyst also may be in the differential diagnosis, but dermoid cyst, there is hyperechogenic pool and there may be fluid level and so on. So different signs by ultrasound can differentiate between these two different cysts, okay? Also, you should differentiate with the endometrioma from malignant ovarian mass or cyst by the presence of solid part inside the cyst, by multilocular cyst, by solid part and cystic parts, by the bilaterality, by the surface papillae or intracystic papillae, by the associated ascites. So there is different signs can suggest also malignancy. So go to the next step, evaluation of the tube for hydrosalpinx with the waist sign. There is constriction in this tubular cystic lesion. This is hydrosalpinx and this is the waist sign, okay? And also you should search for peritoneal cyst. As you see, pockets inside the peritoneal cavity due to adhesions. Okay, it is irregular, it is separated from the ovary. So this is a peritoneal cyst occur with adhesions. Okay, so this is the first step for ultrasonography. Go to the next step and we will search for the soft markers. And as I said before, tenderness of the ovary and ovarian mobility. Please use vaginal probe to do pressure at the site of the ovary. Also, do palpation of the lower abdomen by your hand. Try to move the ovary. If the ovary is mobile, so this is normal. If it is fixed, may be related to endometriosis and adhesions. Okay, as in this picture, this is endometrioma adherent to the posterior wall of the uterus, and this hyperechoic plaque is adhesion to the posterior wall of the uterus. If you push by the probe at this cyst, it will not move freely. Okay, okay. And if you use also the other hand to let the ovary move abdominally, the ovary will not move because of adhesions. Okay, so this is a soft marker and this is the second step of ultrasonography, and with also tenderness. Let us go to the third step and the assessment of pouch of Douglas, and if it is partially obliterated or completely obliterated. As you see in the picture, do transvaginal sonography, do pressure on the cervix, okay? Then look to the anterior rectal wall if it is moving or not. Glides freely on the back of the cervix and the posterior wall of the uterus. This anterior rectal wall glides freely on the posterior cervix and the posterior wall of the uterus. So this is means there is no adhesion, no obliteration of Douglas pouch. Then next step, try to do ballotment to the uterus by the other hand abdominally. Okay, then look to the rectosigmoid. If the rectosigmoid is moving or fixed because of attachment or adhesion to the uterus, if glides in relation to the posterior wall of the uterus and the fundus, so this movement means it is free. There is no adhesion. But if it is fixed and not moving and not glide, so this is obliteration of Douglas pouch. Okay, as you see in this picture, then look to this picture, please. This is an antiverted uterus and this is a retroverted uterus, doing sliding sign for in both of them. As you see, this is the adhesions to the cervix and to the posterior wall of the uterus. Okay, but in RVF uterus, the cervix is shifted anteriorly. So you are using transvaginal probe and replace it in the posterior fornix and try to do pressure on the fundus of the uterus like that. If anterior rectum glides freely over the cervix and the posterior uterus, so there is no adhesion. If after you do ballotment by the abdominal hand, the rectosigmoid glides freely, so the uterus is not adherent. Okay, so the pouch of Douglas is not obliterated. But if there is limited mobility or no mobility or anterior rectal wall and the rectosigmoid not glide freely with this pressure, so this is obliteration of Douglas pouch and it can be either partial or complete obliteration. Let us go to the fourth step. In ultrasound, we are trying to assess the deep infiltrating endometriosis nodules in anterior and posterior compartment. How can we do that? For the anterior compartment, we will put the probe of the transvaginal ultrasound in the anterior fornix, okay? And ask the patient to leave the bladder moderately filled, okay? Because I need the bladder filled to see the borderline of the bladder and to see if and identify any mass in the bladder wall like endometriotic nodule. And by the way, endometriotic nodules usually looks like hypoechoic, irregular mass and tender. And this tenderness is very important sign really. Okay, when I'm searching for the posterior compartment, which include the rectovaginal space, the vagina, the retrocervical area, rectal wall, and Douglas pouch, uterosacral ligament on both sides, McEnroe's on both sides, and the perimetrium. So this is called the posterior compartment. We will put the vaginal probe in the posterior fornix when we are trying to assess the deeply infiltrating nodule of endometriosis in the posterior pelvic compartment. As you see in this picture with transvaginal ultrasound, this is the uterosacral ligament, and this is the perimetrium, and this is endometriotic nodule with hypoechoic lesion, irregular and tender. You will ask the patient if there is pain while you are doing this or doing pressure at this area. She will say, I have pain. Okay, so tenderness is a very important sign, as I said before. Look to this picture, please. This is the rectum, and this is the rectovaginal septum, and this is the hypoechoic irregular nodule, okay, between the rectum and the posterior vaginal wall, okay. And in the other picture here, this is a bladder nodule, endometriotic nodule. As you see, this irregular mass related to the wall of the bladder. Okay, this picture show you the cervix, the uterus, the uterosacral ligament, the pouch of Douglas and rectum, and you should know that any lesion of endometriosis above the level of uterosacral ligament, we say cranial rectal lesion or rectosigmoid lesion. If it is below the uterosacral ligament, we consider it caudal rectal lesion. Okay, how to see the rectal wall and the rectovaginal septum while doing ultrasound, transvaginal ultrasound. You put first the transvaginal probe in the posterior fornix, then gradually withdraw the probe to outside, okay, to see the rectal wall and the vaginal wall and the vaginal rectovaginal septum. This is a very important sites for endometriosis and you should know them. Okay. Okay, what about MRI? Magnetic resonance imaging. First, before doing MRI, you should prepare your patient using the European Society guidelines. Okay? The patient should be fasting for 4 to 6 hours. Also, you should give the patient antiperistaltic agents, intramuscular or intravenous. Why? Because it will give you a better image quality. Okay? The bladder, as in transvaginal ultrasound, should be moderately filled. Then vaginal or rectal opacification can be done or not. This is an optional. How can you do vaginal or rectal opacification? By doing saline infusion inside the vagina or enema in the rectum using saline, or some people use gel of ultrasound in the vagina or rectum also. So this is an optional while doing MRI. As you see in this picture, this is bladder endometriosis. This mass in the bladder wall is in the deep infiltrating nodule. Okay, another picture very special and very informative. This is endometrioma by MRI, and this is fibroid or leiomyoma, and this is the hydrosalpinx diagnosed in the same case. Is MRI has high sensitivity and specificity? The answer is yes. MRI has high sensitivity in diagnosis of endometrioma and also has high specificity reaching up to 91%. And as regards the sensitivity of MRI is about 95%. Okay, so yes, the endometrioma can be diagnosed easily with MRI. What is the differential diagnosis of endometrioma while we are doing MRI? The hemorrhagic cyst, the teratoma, and ovarian carcinoma. Hemorrhagic cyst is different than endometrioma. It lacks the T2 dark spot sign. Also, another difference, resolution happen in 4 to 6 weeks in hemorrhagic cyst, while endometrioma persists. Okay? Also, the acute presentation of hemorrhagic cyst is another difference. What about teratoma? Teratoma really can be diagnosed accurately with MRI, and the fat which is produced due to species material in the dermoid cyst or mature cystic teratoma is really pathognomonic by MRI. So the fat content is easily identified by MRI. Ovarian carcinoma can also be diagnosed by MRI and differentiated from endometrioma. Ovarian carcinoma has a solid parts and enhanced on MR image obtained after intravenous administration of the dye, which is gadolinium. Okay, so simply you can differentiate them from endometrioma. As you see in the picture, this is mature cystic teratoma and this is the endometrioma. Okay, MRI has a diagnostic, as I said, accuracy in detecting endometrioma and the deep infiltrating endometriosis, as in this picture, retrocervical nodule okay, diagnosed by MRI, and this is bladder nodule. MRI appeared to be less accurate for peritoneal disease. For superficial peritoneal lesions, small lesions, okay, limited to the peritoneum and its depth less than 5 millimeter, MRI is less accurate in diagnosing such small peritoneal lesions. Okay, but MRI can diagnose ovarian endometrioma and deep infiltrating nodules. Okay, this is important also to know for whom I'll ask for MRI, because MRI, all of us know it is costly and they're not available in every place. But ultrasound, of course, available everywhere and is cheaper. But MRI is expensive. So MRI is indicated for some people like adolescent, when I suspect endometriosis in adolescent, or women with significant medical conditions, or women with infertility but few pain symptoms of endometriosis. You are in query, you take history and did examination, did transvaginal ultrasonography, you are still not completely sure of endometriosis or not, so you can go to MRI. Okay, so in certain situation you will need MRI for diagnosing endometriosis. Okay, what about computed tomography or CT scan? Is it needed in endometriosis and diagnosis of endometriosis? Actually, CT has a limited role in evaluation of pelvic organs, but it can be used to diagnose cases with infiltration to the ureter and causing ureteric dilatation, hydroureter, and hydronephrosis. You are using CT with dye, and multi-detector CT is the one which is important in diagnosing such a condition. Also, it has its role in diagnosing sigmoid colon nodules, as in this picture, of course, with barium enema, and also should be multi-detector CT scan. Also, a rectal nodule, as in this picture, and enema CT scan also is important. You should do enema before CT with saline. Okay. Let us see the conclusion of the systematic review published in 2016. They concluded that none of the evaluated imaging modalities were able to detect overall pelvic endometriosis with enough accuracy that they would be suggested to replace surgery. Specifically for endometrioma, transvaginal ultrasound qualified as a SPEPAN triage test. MRI displayed sufficient accuracy to suggest utility as a replacement test, but the data were too scant to permit meaningful conclusions. Also, in conclusion, transvaginal ultrasound could be used clinically to identify additional anatomical site of deep infiltrating endometriosis compared with MRI, thus facilitating preoperative planning. Yes, you are doing transvaginal ultrasound or MRI to diagnose deep infiltrating endometriosis, not only for diagnosis but also for preoperative planning. You are planning what you are going to do in this surgery, and of course this deep infiltrating lesion need a very special surgery and a very special experience in endometriosis management from the gynecologist. Okay, okay. Rectosigmoid endometriosis was the only site that could be accurately mapped by using transvaginal ultrasound, transrectal ultrasound, MRI, or multi-detector CT scan. So, our take-home message today for transvaginal sonography and MRI Transvaginal is regarded as the first-line investigation tool for suspected endometriosis. However, TVS cannot detect superficial peritoneal disease. TVS has a high sensitivity and specificity for the diagnosis of endometrioma, and the ability to detect deep infiltrating endometriotic lesion is shown to improve significantly when TVS is performed by endometriosis specialists. And this is very important because not every doctor aware about all signs of endometriosis by ultrasound. So transvaginal sonography should be done with endometriosis specialist. As far as ovarian endometriosis is concerned, transvaginal ultrasound met the criteria for SPPAN triage test with specificity 96% and almost nearly for SIN-out test sensitivity 93%. What about MRI? MRI has high diagnostic accuracy in detecting endometrioma and deep infiltrating endometriosis and less operator dependent. And this is a very important advantage of MRI, that it is not operator dependent, but transvaginal ultrasonography, yes, operator dependent, and they need a very experienced specialist in endometriosis to do it. Okay. Okay, MRI is considered second-line imaging technique after TVS because of higher cost and reduced availability. As far as ovarian endometriosis is concerned, MRI qualified as Senau test because it has sensitivity of 95% and almost as SPPAN test because it has a specificity of 91%. This is the last slide. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura